Video we will discuss about the GI lymphomas. It is a highly important topic. Every time you get an one or two topics questions from this topic. It's a very high heel topic. So GI lymphomas, basically we can classify GI lymphomas into 5 types. First will be your diffuse large B cell lymphoma. This DL BCL around 55%. It is the most common. It is the most common type. Second will be your maltoma. It is around 40%. Third will be your Burkitt's lymphoma, which is around 3%, followed by your mantle cell lymphoma and your follicular lymphoma. Each of 1%. So, some important one-liners you must know in GI lymphomas is: first is most common site is stomach. In stomach, the most common site is antrum, but there is an exception for this. The exception is your Burkitt's lymphoma, which is common in your cardiac and body region of your stomach. And the other one-liners is most common type is DL BCL. This I have told already, 55%. So the two most common types of GI lymphomas are DL BCL and your maltomas. So diffuse large B cell lymphomas are high grade. Whereas your maltomas are low grade. And one more thing I want you to point out is that rarest lymphoma in your GI tract, or the rarest site, is your rectal. And previously I have told Burkitt's lymphoma in stomach is most commonly seen in your cardia and body, whereas your Burkitt's lymphoma can present as terminal ileal mass also. Moving on to the etiologies, the most important etiology I want you to remember is your H. pylori, and it is 100% involved in maltomas. Another etiology will be Campylobacter jejuni and Epstein-Barr virus, especially in cases of Burkitt's. Others will be PTLD, post-transplant lymphoproliferative disorder, celiac sprues, and IBD. And there is something called as Dawson's criteria. There is a separate short video for this. I have already put in your channel, and this involves 4 criteria, out of which 2 is related to your lymph nodes and 2 normal things. One is of laboratory and one is of examination. Here the lymph node criteria includes no clinically palpable lymph nodes, and no mediastinal lymph nodes, and 2 normal is 1 normal laboratory values bar bone marrow biopsy should be normal, and the other normal will be your normal spleen and liver. So Dawson's criteria, for easy remembrance, you will remember as 2N and 2LN. So N is for normal laboratory values like hematological values and normal bone marrow biopsy, and the second N will be for normal spleen and liver, and 2LN will be for the negative clinically palpable lymph nodes and negative mediastinal lymph nodes. And first, moving on for the staging. In staging, basically the staging involves CT, CECT and PET-CT. If lymph nodes is there, then biopsy has to be done to rule out other causes. The staging here used is, classically it is Ann Arbor staging, and you must remember one more name in your staging is that Lugano GI lymphoma staging. Very important. You remember this name, and there will be a separate video or shorts for this Lugano staging of GI lymphomas. The Ann Arbor staging is very easy. 1, 2, 3, 4 stage. First stage is the tumor is confined to only the GI tract. In stage 2, there is involvement of the regional lymph nodes. In third stage, there is involvement of extra regional, that is your para-aortic or your iliac group of lymph nodes. Stage 4 will be involvement of other abdominal organs like liver, spleen or extra abdominal organs. So some of the important points about each lymphomas I want to see. First we will see about DLBCL. It is the most common type, like 54% it is seen, and it is aggressive type. It is of high grade tumor. It can be seen as a de novo. It arises as a de novo, or it can be seen in CLL or follicular lymphoma or myeloma. Coming to your myeloma, it's a very important topic, myeloma. Why? Because it is like 100% there is association between H. pylori and it is a low grade tumor. Each point or each line is an MCQ for you in myeloma. Okay, and other important thing I want to say in myeloma is that if there is translocation of 1118 or 114 and BCL 10 expression, if we tend to see this, then there will be non-responsiveness for H. pylori eradication. So this is one tumor that is 100% associated with H. pylori. Thereby, if we treat H. pylori with your antibiotics, there will be 100% remission with H. pylori kit, that is for used for eradication. So there will be questions related to this. Which of the following lymphomas, that is 100% association with H. pylori, then it will be myeloma. Which of the following lymphoma that can be eradicated with H. pylori eradication, again it will be myeloma. Which of the following which of the following lymphoma will be of low grade, again it is myeloma. And non-responsiveness to H. pylori treatment in case of myeloma includes, the question is very important, which of the following criteria makes myeloma non-responsive to your H. pylori eradication? One will be your translocation 1118 and BCL10 expression, and other things will be your nodal status, like node positives, transmural invasion, and H. pylori negative. In these cases, then we have to go for your chemo radiation, like external beam radiotherapy as a best response. So next I want to talk about Burkitt's lymphoma. In Burkitt's lymphoma, I want to say about 5 points, exactly 5 points. It is also one aggressive tumor. It is seen in younger age group, and we already told if it is going to occur in stomach, then the most common site is not antrum, it is cardia and body of the stomach. And it is most commonly seen in Africans and in children, that is endemic areas for Burkitt's lymphoma. And most importantly, it has also association with EBV virus, that is Epstein-Barr virus. So follow up of your myeltomas, especially after H. pylori eradication. I want to speak about few points regarding this H. pylori eradication. After H. pylori eradication, for follow up, the criteria is Every 2 months you have to repeat upper GI endoscopy and to look for any infection or the clearance of infection. After that, biannual endoscopy for 3 years. This is how you follow a case of lymphoma after H. pylori eradication. Then something I want to tell about your small intestinal lymphoma. The most common site for small intestinal lymphoma is your ileum, and I've already told Burkitt's lymphoma is also common, can present in your ileum like terminal ileal mass, and it is most common in your children of less than 10 years. So treatment will be chemotherapy, and the role of surgeries in lymphomas is only when there is complications. One of the complications that can occur is obstruction, or there can be like local regional spread, or there can be bleeding. Leading to obstruction. So these are some of the indications for surgery. And one more thing I want to say is B cell lymphomas are always chemosensitive, and T cell will always be of surgeries in a small intestinal lymphomas. So let us see few of the questions related to your lymphomas. Which of the following type of lymphoma involves extrahepatic biliary route? So this is one of the lymphoma that we have not discussed. Here the answer is follicular lymphoma. Follicular lymphoma is multifocal in nature. It is one of the lymphoma that is multifocular, and it is very rare. Only 1% of the GI lymphoma is follicular lymphoma, and it will be a multifocular lesion lymphoma. So chemotherapy regime in mantle cell lymphoma of small intestine after surgical excision. So after surgical resection is your R-CHOP. Here R refers to rituximab. This is a monoclonal antibody. All are characteristics of Burkitt's lymphoma except it is an aggressive tumor. True. Usually can present as terminal ileal mass. True. Associated with Epstein-Barr virus infections. True. Common among white people is no. It is an endemic condition, especially common in Africans and children's. And one more point that I have to say here is that HPE pathology, you will see the typical appearance that is called as starry sky appearance. And one more important finding we have told is that it is in stomach. Most common site of GI lymphomas is stomach, but in stomach, and it is antrum. But in Burkitt's lymphoma is particularly seen in cardiac and body of the stomach. Most common GI associated with H. pylori, it is again malt lymphoma. Malt lymphoma is one of the lymphoma that is associated with almost like 100%. So eradication of H. pylori eradication with antibiotics alone will suffice for maltomas, which is true regarding gastric lymphoma. Mostly T cell lymphomas of malt region. No proven relation with H. pylori. No, there is a proven relationship with H. pylori. Clinical and endoscopic features resemble gastric adenocarcinoma. This is true. Most of these lymphomas are common in antral region, and gastric adenocarcinoma is also common in antral region. So the clinical features they present with similarities like weight loss and other features that is common with your GI adenocarcinoma, that is gastric adenocarcinomas. Thank you.